Now for O2 delivery devices, the biggest caution is to avoid combustion. Oxygen is highly flammable, so keeping your patient from blowing up is a good thing. So the big no-no list on the NCLEX and most nursing exams. Number 1, no smoking. This open flame can combust in combination with oxygen. And no static, so synthetic or wool fabrics are a big no-no. Only cotton. And no flammable material like alcohol or even acetone inside of nail polish. We're talking a big risk for explosions here. So keep your patient safe and free from blowing up. Okay, now finally, for the big list of oxygen delivery equipment, I recommend focusing on the reasons why they are used and don't get hung up on the percentages here directly, since it's not highly tested. And a little side note here, many textbooks vary on their numbers in terms of percentages. So our numbers were taken from 3 different textbooks, the Davis textbook and cross-referenced with Bruner and Iggy MedSurg nursing texts. So, starting with number 1, NC, nasal cannula. The description is 1 to 6 liters per minute, and it delivers 25 to 45% oxygen. Again, focus on the reason it's given. So write this down. Used for short-term use, like with low oxygen after surgery, big key term there, or for long-term use, which can really dry out mucous membranes in the nose. So we typically use humidification for that long-term use. Next, we have the face masks. So first up is the simple face mask, 6 to 10 liters per minute at 40 to 60% oxygen. Now this face mask is used in exchange with a partial rebreather and even non-rebreather. So for partial rebreather, that also gives 6 to 10 liters per minute at 35 to 60%. Now these guys look very similar to the non-rebreather. But really the key difference is the flutter valves on the sides. The partial rebreather does not have those, and the simple face mask doesn't have a reservoir bag. So the big head honcho here is the non-rebreather. The acronym is NRB. So it delivers 10 to 15 liters per minute and is used in medical emergencies. It delivers 60 to 100% of oxygen. So the key point to write down, focus on this. So it's used during carbon monoxide poisoning, since only high flow O2 at 15 liters per minute will help eliminate that carbon monoxide and treat the hypoxia here. Now, if the reservoir bag is fully deflated on inspiration, we simply increase the oxygen flow. Huge key terms, a lot of students get this wrong. So you must monitor the bag and the valves to ensure the bag is more than halfway full. Now, don't let the NCLEX and don't let exams trick you here. Do not open the flutter valves. These valves should be closed to help more oxygen get in during inhalation. And don't tighten the face mask straps first if the reservoir bag is fully deflated. Tightening the mask helps reduce leaks directly, but doesn't necessarily increase the reservoir bag. So once again, if the bag is fully deflated on inspiration, just increase that oxygen flow. Next, we have the Venturi mask, 4 to 10 FiO2. Now, key term, this is the most precise oxygen delivery device. So the memory trick we use are the double V's here. V for Venturi mask, just think V for very accurate O2. Typically used for patients with unstable COPD who cannot tolerate changes in oxygen concentration from other devices. And lastly, we have a face tent. This is specifically used for facial trauma and burns, since it has high humidification. So just think of the double F's here. Face tent for face trauma. Now for the top missed exam question. A patient recovering from surgery in the postoperative area suddenly becomes confused. The pulse ox reading shows a drop from 98% to 90% on room air. What is the most appropriate intervention? Now just think here. The key term was post-op or newly post-op, recovering from surgery. Those are big key terms. We know that this short-term drop in oxygen saturation can be solved with a short-term solution. So the most appropriate intervention is that nasal cannula. Now switching gears to BiPAP. Typically this is the last line oxygen device before ET tube or endotracheal intubation. Most commonly used for clients with worsening COPD who have high levels of CO2 retention, leading to that respiratory acidosis due to that decreased gas exchange. So the BiPAP is that positive pressure machine that forcefully pushes air deep into the lungs, giving much needed oxygen while expelling CO2. Talk about forceful gas exchange, right? This is primarily used to prevent respiratory failure caused by low oxygen and high CO2, which is common for clients in worsening COPD. Now, some key terms that you should know for respiratory failure. We have two types. It's either from low oxygen, called hypoxemic respiratory failure, from that low O2, or from high CO2, called that hypercapnic respiratory failure, over 45 CO2. So just think hypercapnic is from high CO2. Now the priority here is for a BiPAP. So the memory trick we use, just think hypercap, give a BiPAP. Again, it's very common with clients in worsening COPD with that decreased gas exchange. Now, very lastly, we have intubation, as mentioned before, our endotracheal intubation. Now, this is the ultimate solution to keep the airway patent. So we stick a tube directly into the trachea to ventilate the client manually via a bag valve or a ventilator machine. Now, this is typically used during surgery to keep the airway open, or as a last line for clients with a compromised airway, like patients who code or allergic reaction. We get swelling in that throat region, which closes the trachea, and even patients who are post-thyroidectomy, where they get swelling near that trachea. Now, the big stuff to write down is the complications. So write down VAP, ventilator-associated pneumonia. Always a huge key point on many exams. So we have to key term, reposition the client side to side every 2 hours to help mobilize secretions. And another key point number 2 is oral care. We use chlorhexidine every 2 hours, typically followed by oral suctioning. And very lastly, you want to monitor for key signs. We have positive sputum culture, a fever, as well as a chest x-ray with, key term here, new infiltrates. All these three typically indicate infection and worsening VAP, leading to that ventilator-associated pneumonia. All right, guys, that wraps it up for this segment. Don't forget to take your quiz and download the study guides.